Hello, this is Dr. Siddharth, third year orthopedic resident, and this is my first YouTube video. I am trying to deliver important topics and important notes, which will be beneficial for all the postgraduates in their residency. Coming to our topic, today we will discuss about compartment syndrome, the introduction, the causes, the pathophysiology, anatomy of the leg and the forearm, the clinical features, investigations, and treatment, along with the complications. So, coming to the introduction, definition of the compartment syndrome. This condition is developed when the osseous facial compartment pressure increases. What happens next? This causes decrease in the tissue perfusion, causing the neurological deficits, the muscle necrosis, and what so important complications. We will look about the causes. In causes, we can learn about a mnemonic TAG, where T stands for trauma. Trauma can be of different types, like tibial diaphyseal fractures, distal radius fractures, supracondylar fractures, forearm shaft fractures, crush syndrome, or any soft tissue injuries. Trauma can also include the burns. Tights. Tight includes the cast and the dressings we do after the post-op surgery procedures. The tourniquets. Tourniquets can cause post-ischemic swelling, the reperfusions. A stands for artery. Artery means arterial injuries, the bleeding disorders. Arthroscopically, there can be fluid extravasations or IV fluid extravasations. G stands for gunshot injuries. The pathophysiology of compartment syndrome. How does it develop? See, the thing is, whenever the swelling of the muscles happen, like after the injury, after the post-surgery swelling, this causes increase in the compartment pressure. The compartment pressure increases. Normally it is around 10 to 15 mmHg, but this increases to a significant value, which causes venous and lymphatic obstruction. This venous and lymphatic obstruction causes increase in the intra-compartment pressure, which exceeds the compartment perfusion pressure, which we'll talk further in later section. This increase in the CPP, compartment perfusion pressure, causes release of vasoactive substance. The release of vasoactive substance can further causes cell membrane injury. The cell membrane injury can cause increase interstitial edema. This increase in the interstitial edema will further cause increase in the tissue pressure. Pressure increase in the tissues, which will cause decrease in the pH and causes nerve conduction speed decrease. So the end point resulting from all this pathophysiology is neurological deficit, the necrosis happening in the muscle, and the contracture along with it, along with the non-viable extremity, which is the end point, causing irreversible changes in the muscle. Here we can see the different compartments of the leg and the forearm. One by one, let's look upon it. In the leg, basic, the compartments are divided into anterior, lateral, posterior. Here we can see this is the anterior compartment, this is the lateral compartment, and this is the posterior superficial and the posterior deep compartment. The anterior compartment muscle groups mainly includes the tibialis anterior, the extensor digitorum longus, the extensor hallucis longus, the peroneus tertius, and the tibial vessels and nerves. Here we can see tibialis anterior muscles and the extensor hallucis muscles group. In the lateral compartment, main muscle group are peroneus longus, peroneus brevis, and the superficial peroneal nerve. In the posterior compartment, which is divided into superficial and deep, the superficial group includes the gastrocnemius, the soleus, the plantaris, and the sural nerve. And the deep compartment includes the tibialis posterior, the flexor digitorum longus, flexor hallucis longus, and the posterior tibial nerves and vessels. So any injury causing increase in the pressure in any of this compartment can cause decrease in the tissue perfusion and cause the death of the muscles, leading to compartment syndrome. Likewise, in the forearm is basically divided into two major compartments, the volar compartment and the dorsal compartment. The volar compartment is divided into superficial, this is the volar compartment, the superficial and the deep compartment. The superficial compartment groups includes the flexor carpi radialis, flexor digitorum superficialis, pronator teres, median nerve and the ulnar nerve. The deep compartment muscle group includes the flexor digitorum profundus, flexor pollicis longus, and the pronator quadratus. In the dorsal compartment, we can see the muscles includes the extensor digitorum, the extensor pollicis longus, the abductor pollicis longus, and the extensor carpi ulnaris, along with the supinator muscle group. And in the mobile ward, the three muscle groups are the brachioradialis, ECRB, the extensor carpi radialis brevis, and extensor carpi radialis longus. Any pain while passive extension of the wrist or finger can cause pain over the dorsal aspect or the dependent compartment of the muscle. So this will suggest the development of compartment syndrome in the forearm muscle group. Coming to our next subtopic, the clinical features of the compartment. The clinical feature of the compartment syndrome are basically 5P. The first P stands for pain. Pain which will be out of proportion to the injury. Pain will be on passive stretch. Pain cannot be assessed in sedated or comatose patient. Hence, we have to look for different clinical investigation modalities, which we will talk later. Another P stands for pallor. Pallor can be happening in the toes or in the fingertips. We have to look upon. Another is paresthesia, the pulselessness, which is the very late sign and may lead to amputation. If this sign is appearing, then this is clinically suggestive of a very late sign of compartment, and the compartment syndrome had already went into irreversible changes. The last P stands for paralysis. So, coming to the investigation, we will have to get x-rays to rule out any fractures. This is the most crucial step, as compartment syndrome, which we oftenly see in the casualties, are mostly due to the fractures, and ruling out fractures is the most important point to rule out compartment syndrome. Coming to the next modality, the measurement of the compartment pressures should be measured by different modalities. Most common is using of the manometers, the handheld manometers, the white sights technique, or the laser Doppler flowmetry. So coming to the intercompartment pressure, the pressure which is inside the compartment, this pressure is normally less than 10 millimeters of mercury, but if on measurement any significant value above 30 millimeters of mercury is suggestive of emergency fasciotomy. We have to be very critical about this decision, because this can save or lead to amputation of a limb. Also, delta P, which stands for the compartment perfusion pressure, which we talked earlier in the pathophysiology. This CPP is measured by subtracting diastolic blood pressure minus intercompartment pressure, and this pressure is normally more than 30 millimeters of mercury, and less than 30 millimeters of mercury of delta P is suggestive of emergency fasciotomy. So these 2 points should always be in your mind. Any comatose patient or any patient, like in children in whom there is no clinical evidence of compartment syndrome, like the patient is not responding to the passive stretch or the child is continuously crying of the pain, we have to go for the intercompartmental pressure measurement with the manometers and to look for the ICPs and the CPPs. Coming to the treatment, if there is risk of impending compartment and we have confirmed with the manometers, we have to go for emergency fasciotomy. For leg, The emergency fasciotomy we go ahead is with the 2 incision or 1 incision. In the 2 incision technique, one incision is taken on the anterolateral aspect and another incision is taken on the posteromedial aspect. On the anterolateral aspect, the incision basically relieves or decompresses the anterior compartment and the little compartment, whereas in the posterior medial compartment, the decompression happens in the superficial posterior compartment and the deep posterior compartment. In the forearm muscle group, the 2 incision decompression is done, fasciotomy is done. The polar compartment is specifically for the superficial flexors and the deep flexors group, along with the carpal tunnel release, and the dorsal incision is for the extensors muscle group and the mobile ward. We will look the 2 incision fasciotomy of the leg in bit clinical details. So in the lateral view, we can see the leg. The anterolateral incision is taken halfway down the leg, 2 centimeters anterior to the fibular head. So we can see there is a fibular head. This is the fibula, and the incision is taken 2 centimeters anterior to the fibular head, and the incision is taken around 15 centimeters long. This line which I am drawing is basically over the anterior intermuscular septum. So the anterior intermuscular septum is dividing the anterior compartment and the lateral compartment. So we can easily access both compartments with a single incision. Primarily, we have to go for the anterior compartment. We have to release the muscle. We have to use a dissecting scissor and open the fascia, superior and inferior, releasing the pressure of the anterior compartment. Further, for the lateral compartment, we have to put a nick on the fascia and open the lateral compartment fascia too, causing decompression of the both anterior compartment and the lateral compartment. For the posterior compartment, we have to go for posterior medial incision, as we can see in this image. This incision is taken 2 centimeters posterior to the posterior medial border of the tibia. This is the tibia and this is the posterior medial border. We have to take 2 centimeters posterior to the posterior medial border of the tibia, and the incision should also be 15 centimeters long. It can vary as per the fracture site, but generally taking a aggressive approach is better than regretting later. So the incision is taken, and this incision can easily access us towards the deep and the superficial posterior compartment of the posterior compartment, causing decompression of both the compartments in a single incision. This double incision is always better than one incision technique, as there is fibulectomy done along with the fasciotomy of the all 4 compartments. But in 2 incision technique, there is no cutting of the bone, so there is no removal of the bone. It is faster and relatively safer. And the complications of the compartment syndrome we can learn with the mnemonic VIC. VIC, where V stands for Volkmann ischemic contracture, I stands for infection, and C stands for cut, basically amputation. So the complications of the compartment syndrome stands for VIC. Or can also happen complications like permanent nerve damage or kidney damage due to rhabdomyolysis. So basically, this was all about the compartment syndrome. Thank you.